So, all right, wonderful. So you guys can see the screen in its entirety? Wonderful. Well, thank you for giving me the opportunity to speak to all of you. It's pre-med students from what I understand. And you guys are from various areas and just want to understand a little bit more about the different fields. So I'm a family medicine physician. I'm Dr. James, and I'm from Florida. I do outpatient primary care medicine, and I really want to try to make this interactive. Unfortunately, I have not done any PowerPoint presentations in Zoom, hence the technical issues in the beginning, but thank you for bearing with me. I think especially towards the end, when I have case studies, I want it to be more interactive. So if you guys have any input, ideas and thoughts as well, okay? So just to start off with, I have nothing to discuss. So I just wanted to go through just an outline of what we'll be talking about today during the presentation. I'll be starting with my background and just talk a little bit about my journey and how I got here, discuss how you become a family medicine physician and the training you have to go through for that, and job opportunities as a FP, which is family practice physician. Then I'll talk a little bit about pros and cons. I like to be very transparent and have full transparency. I wished I had more insight into the pros and cons when I was a pre-med student or even a med student, but I'd love to share some pros with you guys. And then we'll go through basically like it's a shadowing day, you know, I'll just walk you guys through my day, starting from the beginning till end, throw in some case studies there. And then that's where I would like you guys to unmute yourself and just share what your ideas are. And then at the end, ask any questions you have. So just to go through my background, I am from India and I was born there. My biggest role model was my grandfather, who's in the picture in the top left. And he was a physician himself. He practiced from our house and he had his clinic in our house. And I grew up seeing what a family medicine physician is, the old school way. And so he's my biggest role model to this day. He was a musician, he was an artist, he was an actor, he loved gardening, he loved animals, he just did so much community service. And so that's what I wanted to be. I wanted to be him. And I wanted to be a doctor since I was young for that reason. And I came here for high school. I started 9th grade here in the US. I was in Chicago. And even starting then, I really enjoyed being involved in the community, being very proactive. With my friend, I started the Health and Wellness Club, did a lot of community service, and then I decided to go to Loyola for pre-med, and I actually kept a very open mind, you know, because I feel like if we want to for sure know that this is the path that is meant for us, we have to explore other options. So I actually went and shadowed a nutritionist. I was considering optometry for a while. I was like, you know, I love community service a lot. Maybe I'd like to be a social worker. And so I explored many fields, even being a counselor, because I really liked mental health and psychology. And I explored many fields and finally decided that I wanted to be a physician, and not just any physician, that I wanted to be a family practice physician. So I majored in biology, pre-med track. I minored in music and psychology. I was very involved in a lot of community service activities, on the board for different organizations. With my friend, I founded the Stop Diabetes organization, and I was involved in Unite for Sight. I traveled back to India and did camps, and that's the second picture on the left side. I did a medical camp back in South India. And it was wonderful. I came back, did the MCAT and the whole deal, got into med school, and I decided to go into DO school because of the holistic approach, the mind, body, spirit approach. And I really was attracted to manual therapy, and I wanted to have that skill set. And so I went to Des Moines University in Iowa and loved it. You know, those years are difficult, but as long as you have the right spirit, mentality, perseverance, you make it through that. Some of the best years of my life. And some of the things that got me through that time, again, was being involved in the community. And I became a yoga instructor and taught yoga on the Saturdays in our gym. And I also started up my own Bollywood class and did a Bollywood fitness class on Friday nights, which everybody loved. And it was just such a great way to de-stress. And at that time I was thinking, I'm like, you know, again, crossroads, right? Like, it's time to apply for residency. What do I choose? I don't know. Like, I like mental health, I like holistic medicine, I love preventive medicine, nutrition. And so I did a couple of different audition rotations. You get the opportunity to do that as a medical student. You have core rotations you have to do, but then you can pick a couple of electives. So I traveled all throughout different states doing different electives that I was attracted to. I did family medicine, I did OMT, neuromuscular medicine and manual therapy rotations. I did rotations in psychiatry. I did combined FP, OMT. So again, exploring what calls my interest. And again, I came back to family medicine because the thing is, in FP, you are the one determining which way you want to expand. It doesn't confine you. And that's the beauty of it. It's just that whatever continues to inspire you, you can mold yourself into it. And so I chose family medicine residency in my hometown, Chicago. I went back there, and it's a 3-year program, residency for FP. And what was great was we were the only residency program there. So we got to run the hospital, and we ran the clinic, and we did it all. We did deliveries and OB care, we did procedures. And so again, as an FP, you hone your skills in whatever calls your interest. And so those things for me were preventive medicine, outpatient medicine, manual therapy. And during residency, I actually created a rotation called integrative medicine rotation, because I wanted to work more with a lot more holistic practitioners and see how I could incorporate that and give that opportunity to my fellow residents as well to explore that, because that's the new up and coming thing, you know? So that's basically my path. Does anybody have any questions about how to become an FP? How many participants do we have? 12? I'm so curious to know.
I think we have 15. But
awesome.
If anyone else has any questions, they can also use the chat.
Awesome. And how do I access the chat? Where do I look for that?
It might be difficult because you have your PowerPoint going on right now.
Yeah. So you will see that?
Yeah.
Okay, awesome. Perfect. So let me see. So yeah, if you guys have any questions, just ask that and just notify me, and then I can go over that, okay? So what is family medicine? It's basically primary care. You know, while most specialists are limited to just focusing on one organ system or a disease that is pertinent to that system, as an FP, we are qualified to treat multiple organ systems to our level of comfort. And so we are here in our healthcare model to be the first forefront healthcare workers to screen the patients, to get their wellness going, and to connect them with appropriate resources and the specialists. And we manage ourselves many pathologies to our level of comfort. And so many people wonder how it's different from internal medicine. And so internal medicine is very similar to FP, except that FPs have more in-depth training in OBGYN, women's health, in mental health, psychiatry, and a more family-oriented care. Not to say that internal medicine doctors don't do that. I have come across some internal medicine doctors who do Pap smears, which really intrigued me. But we're just more trained for these tracks. And our scope of practice is basically what you train for in residency and the CMEs you take. So for example, I did not want to do deliveries, so I wouldn't be going into the OR for C-sections aggressively like my colleague who wanted to do OB. And so he would try to catch all the C-sections that he can. Others who may want to do full scope primary care in the rural area, they try to get in to do everything as much as they can. Versus for me, I wanted to do more outpatient medicine, get some procedures under my belt. And so on here, I have a list of procedures that FPs do. Not everybody does this, but again, these are things that we could do. So that is something that not many people are aware of. The wide scope of our practice, all the procedures that we can do. So in my clinic, I am regularly ordering EKGs, interpreting them. My partner, he orders sleep studies and orders all the equipments for that. We both do pulmonary function tests for asthmatics, for COPD patients, joint injections. So, you know, this can be for tennis elbow, for, you know, osteoarthritis of the shoulder, for osteoarthritis of the knee. IND is something that's everybody has to be comfortable with. It's pretty mainstay. You know, if somebody comes in with an abscess, you have to IND it. And skin biopsies, I do that very frequently so that you don't have to send off the patient every time to a dermatologist. And then the rest of the list is over there. I regularly do Pap smears. I trained in doing colposcopies, which is taking a biopsy of the cervical tissue. I don't do deliveries now, but I did have to do almost 50 deliveries during residency, had to assist with some C-sections, did a couple of circs, did a couple of lumbar punctures, did get trained a little bit in doing ultrasound, but we don't have that in our current clinic, did a lot of intubations, central lines. I'm not too interested in Botox, so I didn't get trained in that, but many other doctors do cosmetic procedures. You do close reduction of the joint, you know, if a finger is displaced or something like that, and microscopy. I do that in my clinic just to kind of get a quick read, because sometimes BV yeast infection, it can be a little hard just based on the looking and patient's presentation. So looking at it in the microscope is just a great way to expedite the treatment, right? So as far as job opportunities for FPs, there is a lot of demand. In fact, the projection is that by 2033, there's going to be a great shortage of family practice physicians by 139,000. That's a lot. So you can choose various settings for your practice. You can choose outpatient medicine. Again, that's what I do. So you can work in private practice for a large health system, for direct primary care. Sometimes there's, you know, direct primary care is a little bit different from concierge medicine, but sometimes people use it interchangeably. And I think you guys are bringing on some of those doctors, which is awesome. You can work in nursing homes. You can be in an academic setting. You can just do home visits, be an expert witness, be a consultant or medical director for other organizations, work in urgent care. And you can even do locums jobs. So like if you have family commitments and just need to take some time for your family and just want to do some jobs on the side when there's need for coverage, you can do that. I've actually done that last year. And the picture that you're seeing, that beach side picture, is when I worked a locums job for Mount Sinai in Palm Beach, where I mean, they basically paid for the hotel and I was living on the beach for 2 months. I'm like, score, you know, this was great. And then you can work in the hospital setting. And some doctors do both. Some community doctors have their outpatient clinic and they also do rounds in the hospital. That's a lot. It's a lot more demanding. But then we have internists, right? People who are just like 14 on, 14 off. They may just do days, just do nights. But you know, being in the hospital was just not for me. I really enjoyed the learning experience of it because to be a good outpatient physician, you definitely need to know what's happening in the hospital. Um, and so you can work in the emergency room, you can work as a hospitalist, again, in the academic setting, you can do locums job in the hospital. And another great thing about FP is just the practice freedom, right? You can pick up many things on the side as you wish. You can have non-medical or medical interests that you're doing on the side. So the pictures of me doing yoga here and the newsletter that I published are just some of the things that I do on the side because I'm also a yoga instructor. So I do teach on the side. You can be an influencer, you can make your hobbies more serious, you can write and blog. And this is something, it's not just about being an FP, it's just as a doctor, you can do this. You can be an influencer and just really reach out to more people. Let me see. Very good. So what can be challenging in FP? So this is a picture of me when I was in residency, and I was seeing like neonates and toddlers at that point. Right now I see 4 and above. So this picture is of me after I was doing a general check on I think a 2-year-old or something, and he just peed on me. And so that's what you get, and you just have to move on. So that was just a funny story on the side. As far as the work-life balance as an FP, like I said, you can work as hard as you want or as little as you want. It's really about what you choose for yourself. Some people are much more fast readers, more efficient in typing and charting, and they get done with their work fast. Others may take on multiple jobs and they may work on the weekends as well as the weekdays. And so it's really just about finding that balance within yourself. And so charting is something that you're going to find out later. None of the doctors like it. It's not just an FP thing, but we definitely have a lot of charting to do, a lot of clicks to do, because there's a concept that we're now trying to look more towards the quality of care and save people from going into the hospital, doing screenings, catching things early on. So in FP, we're kind of in charge of looking at all these things and basically checking off, many boxes, as you could say it, but you always have to work on keeping everything a lot more personable rather than just making it all be about charting and checking off boxes. And it's true, everybody talks about the paperwork that outpatient family care doctors have, but if you have the right team to help you with all of that, it won't be a big problem. Um, Again, you have to learn your style of practice, how to be efficient, but some of the things that FPs have to do is fill out a lot of like return to work form, medical leave of absence, FMLAs, disability forms, prior authorization for medications. Oftentimes we have to hop on the phone with insurance companies and talk to the doctors from there, justifying why we want a specific study ordered for the patient. Like, if I'm ordering an MRI and the insurance is like, oh no, the MRI of the breast is not needed, then I have to calculate the patient's like TC score, risk of breast cancer, and explain to them. And so those are the not so fun side, I'm not going to lie, but there's things that we are obliged to do to take really good care of our patients. And the pay. So I wanted to show you guys this graph. And this was the 2019 Medscape Family Physician Compensation Report. Of course, the family physician's salary is a huge range, again, depending on all the different side hustles you have going on, what kind of job, which company you work for, is it your own practice, are you working for someone else, are you doing multiple jobs, right? But it's third from the bottom. So that's why I'm saying here, if you're a family medicine physician, if you're an FP, it's not about the money. Then what is it about? It's about many other things. We go into FP because we are passionate about it, because we love to work with families, we love the opportunities. So the opportunities are immense. You can work full scope in a rural setting where you're doing lots of procedures, where you're treating a full range of conditions, because specialists are hard to access, right? So you need to take care of urgent things. You'll be doing OB, pediatrics, geriatrics, everything. And then you can choose to be procedure heavy or not be procedure heavy. You can work in a urban setting, rural setting, city setting. You can work inpatient, outpatient. And then the other aspect I touched on already, like if you're still not sure exactly every interest of yours, FP is great because then you can continue kind of listening to your calling and tailor your final career, whatever you wish to manifest, to what your final interest is. And what we do is we take CMEs along the way, or later on we can go into fellowships for those specific paths. And so there are many fellowship opportunities. As an FP, you can go into high-risk OB, you can do sports medicine, integrative medicine, neuromuscular medicine, which is something that I was interested in, addiction medicine, which a couple of my friends did, geriatrics, reproductive health. Many doctors I know have done lifestyle medicine, hospice and palliative care, and sleep medicine. So it's a wonderful opportunity because you have all these other things you could specialize in. And again, I bring back work-life balance, because if you choose the right job for you, and if you know how to negotiate, and you let them know, hey, these are the hours I want to work, and this is the kind of way I want to train my staff. And if you train yourself to be a good leader, to use your resources, and to become very efficient at your job, you can get out on time. You can get things done on time, you know? And I really value work-life balance, and that's something that I really take pride in my job, in my life, is just that I'm there for my patients, but I'm also there for my family. And that's very important, because as physicians, I feel like oftentimes we can be hypocrites where we just kind of work so hard. And that was pre-med and med school. But once you are in your career, it's a marathon. And so you want to be able to be healthy, because if you are not mentally okay or physically okay, your patients can kind of tell that this doctor is not coming from a place of honesty. One of my patients one day told me, he was my first or second patient of the day. He was just like, Dr. James, how do you just have so much energy and you're always smiling? I'm like, because I had a great weekend. I just came back from a Saturday, Sunday off, and I'm happy. And so patients are attracted to that. They come to us for healing, for wellness, and they want to see that in us. So that's why it's important. We cannot just be like, oh, I want to make more money, I want to work as hard as I can. No, it's about a marathon, and it's about serving others, right? So you really want to have that work-life balance. And FP is a lot of fun. It is so gratifying if you love being an FP. Of course, for people who don't understand the cons of it and just get bogged down and jaded by it, it's not a happy place. Or if you don't have the work-life balance, it won't be a happy place for you. But for those who are, you're like a family member to the patient. One of my patients came to me a couple of months ago, and she's only in her 40s, but she's like, I'm so glad I found you. You're a young physician, and I was waiting for 5 years to get in with the right doctor who I can go to the grave with. And I'm like, that's kind of like, they're like welcoming us into their family. As their family medicine physician, that's the role that we have. Unlike specialists, some specialists do see patients throughout their life, but an FP is like a family member that's there with them, and they see us as being there with them for long term. So that's a great honor. Sometimes when devastating things happen in their family, one of my patients' son overdosed and passed away, she called me. In between my patients, I was there for her because she's like a family member to me. And it really matters a lot to me. That gratifies me a lot. And it adds a lot of meaning to my life, what I do. So I just wanted to walk you guys through a day in my life. And this is where the questions start. And I want you guys to get more interactive, okay? So I work a 8 to 5 job. Oftentimes I get out at 6:30. And that's because I have a lot of charting to finish, patient callbacks and everything to do. So when I get there in the morning, I do morning huddle with my MA, my medical assistant. I work on all the tasks because usually when we get back into the clinic, there's a lot of labs and images and patient questions and many things waiting for us, right? So I try to work through those. And then my schedule begins at 8:15. I'm doing different kind of visits, scheduled visits, walk-ins, acute visits. I'm speaking to other consultants on the phone. I'm doing telemedicine visits, doing procedures. I have a 1-hour lunch break, which is basically also when I call patients back and talk to other people. We have sometimes the staff meetings, and then I go again till 4:35 seeing patients. And after that, I'm sitting there looking things up for the next day. I prep for the next day. I finish up my charts. I call people back, fill out all the forms, and just all these kind of paperwork stuff. On average, right now, I'm seeing between 12 to 18 patients a day. With COVID, the numbers kind of fluctuate. Sometimes, like right now, we're having a Delta variant COVID resurgence. So because of that, many patients actually are canceling appointments because they don't want to come in to the outpatient center. And so then we are trying to switch as many patients over to telemedicine as possible so that we can continue the care, right? All right, so how should we do this? Can I have everybody like who's interested in participating maybe unmute their mic if they're comfortable with it, unless there's like a crying baby or a barking dog or something, because these are the cases that I wanted to go through with you guys. I'll give you guys a second if anybody wants to unmute themselves. Okay. Trying to work this. Okay. All right, so imagine you're with me, right? We're in the clinic, it's 8 a.m. I open my inbox and I am going through my results that are back. And so I see that one of my 65-year-old patient, let's say he's a male, he's an insulin-dependent diabetic. He has history of heart failure and he's on the water pill, Lasix. And for his high blood pressure, he also takes losartan, spironolactone, metoprolol. Basically, his result comes back that his potassium is 5.8. That's a little high. So that's not good. So what should we do? Does anybody have any idea? Kind of like, I have put in differentials here, and the differentials include kidney injury. It could be diabetic ketoacidosis, right? When his blood sugars are going really high because he really had to have 2 cups of ice cream the night before. Or is it drug-induced hyperkalemia? That's what this is, right? High potassium is hyperkalemia. It could be dehydration, or it could be hemolysis. What's hemolysis? Does anybody know? Hemolysis? Anybody, take a guess. I want to hear somebody's voice.
The rupture of red blood cells?
Yes, very good. Wonderful. Exactly. So what we usually do when we get a high potassium is, you know how they have to put the tourniquet, right, to draw the blood? And so sometimes if they do that too long because the patient was a hard stick or they made it too tight, sometimes the red blood cells can rupture. And so oftentimes the highest reason for a high potassium, the most likely reason is hemolysis. So we don't just call up the patient and be like, hey, your heart's going to stop probably, go to the emergency room. No, we don't do that. We tell them, hey, your potassium came back high. How are you feeling? And so I called him, I checked in on him. He was feeling completely fine. And I looked at his medications, and there are a couple of medications on here that can drive the potassium up and also down. Insulin, for example, and Lasix bring it down. However, the losartan and the spironolactone can increase it. So what I did was I called him, made sure he was feeling fine, let him know what kind of symptoms to look out for. And then I told him we're ordering stat repeat labs. So we have to get repeat potassium right away. And so I ordered a repeat potassium. He basically got it done. And, I went on to see my first patient, and around lunchtime, I got the result back, and it was still high. It was 5.9. And so then at that point, I actually started adjusting his medications. I had him stop his spironolactone, and I had him increase his Lasix, the water pill, to pull out more potassium and put in a stat referral for him to get in with a nephrologist, because guess what else was going on? His kidneys were starting to go out of whack. So a little bit of acute kidney injury as well. So it's multifaceted. It's multiple things going on at the same time. And as a primary care doctor, you communicate with the specialist. So I have a close relationship with the nephrologist. So I messaged him through a secure messaging system and let him know why I'm sending him, my patient, to the nephrologist, and what kind of things to look out for, and what my initial management was, so that he can take it up from there. Any questions about that? All right, guys. So now we're going to go see our first patient, okay? It's 8:15. Our patient's roomed. And by the way, all the facts here, like patient demographics, are a little altered, just so that, or, not fully disclosed, just to kind of maintain the privacy of my patients. So the first patient, let's say she is in her 20s. She is coming for follow-up for decrease in appetite. Oh, I see the chat feature. I'm so sorry, guys. I just discovered this. I will answer these towards the end, okay? Just so I can continue with the flow. I feel like it's so old school, even if I'm not. All right. So we're going to see her, and she is coming for follow-up of decrease in appetite. I have seen her about 4 times at this point. The first time as a new patient visit. And she was just like, hey, doc, I have had history of decrease in appetite. Is something I've been dealing with for a long time, but I'll work on increasing my protein and try to have 3 meals a day. And I'm like, is everything else okay in your life? Oh yeah, everything else is fine. My husband is supportive. I'm going to send him to see you. So I see her husband. He's also my patient. I see that he's happy with her. She's happy with him. Everything looks fine. And then I ordered a couple of labs on her. I had her come back a second time. Labs looked fine, right? And she came for a follow-up of wart removal. So I did the cryotherapy, the liquid nitrogen freezing for her. And then the third time she comes to me 1 month later is because she was in an anaphylactic shock, and I had to send her directly to the ER from my clinic, because what happened was she has a lot of allergies, and she has allergic to pet dander, and she got exposed, and she did not look good coming to my clinic. I gave her some medications and sent her on the way to the hospital, to the ER. And so now today is her 4th visit, right? She's coming back to see me. I had done some repeat labs on her because the initial labs showed the hemoglobin was a little bit low. Let's say it was 11. So now I'm doing the repeat labs, and it's showing iron deficiency anemia. Her hemoglobin is now 9.9. So that's a significant drop in 3 months. Her ferritin is low at 6. Her iron binding capacity is high. So basically iron deficiency, okay? And she just isn't focused. Her eyes are like everywhere in the room. She looks a little frazzled, and she's like, doc, I'm not at all wanting to eat. And I look at her vitals, and she's lost 5 more pounds since the last visit where she was having the allergic reaction. And that concerned me. And now, during this whole time, I had tried her on one medication, cyproheptadine. Sorry, it's misspelled. It's supposed to be CYPRO, heptadine. And that gave her side effects. And she chose that one because she did not want to try other medications that I recommended, which would include hormonal therapy, antidepressants, counseling. She didn't want to try all of that. But she did ask me, hey, how about medical marijuana? Which I get a lot from my patients, but I'm not trained in medical marijuana. So I have to advise them, hey, I cannot medically prescribe it for you, but it may increase your appetite. You could go to another medical marijuana licensed physician. I'm not opposed to it, but then I counsel her on possible side effects. Sometimes it can affect your clotting factors, your liver. It can make any kind of psychological symptoms worse sometimes. So I'm sitting there thinking, what could be going on? The iron deficiency is probably from malnourishment. Why does she not want to eat that much? She looks very frazzled today. And I asked her one thing, I'm like, hey, do you feel depressed? Have you ever felt depressed? And she's like, since my mom moved in 1 month ago, I have not been able to focus on anything. And without divulging too much, again, because I don't want to reveal any patient information, she basically tells me about all the trauma that she's faced in her life, abandonment, abuse, physical abuse, and all these kind of things since her childhood, since she was 5, and starts crying. And this was a 15-minute appointment, but you cannot just kind of be like, oh, these are your labs, you're still losing weight, too bad, there's nothing else I can do for you, and rush out. You really have to kind of dig further and develop that relationship with the patient to kind of tune in and peel the onion. And so when I dug further, I understood, right? She has PTSD, she has anxiety, she has depression, and she's very resistant to treatment because she has very poor insight at this point about what she's dealing with. So I spent a lot of extra time counseling her, just listening to her. And at the end, finally, this patient who was like a thick, hard shell at the beginning finally softened up and told me at the end, thank you, Dr. James, for listening to me. And was a lot more receptive at the end to medical therapy, which I recommended. And so I started her on Remeron. And so we'll see when she comes back how she is. But the main takeaway from this is, don't forget the mind, body, and spirit aspect of any ailment. Do you guys have any questions about that case? All right. Okay, so it's 8:30 now. I'm actually still in the room with the patient and I didn't want to rush her. So it's actually 8:45 now. My 8:30 patient is here. I'm running 15 minutes late, right? This is the reality of family medicine. And I'm like, okay, gotta go see the 8:30 patient. But then the front desk comes to me and tells me that interventional radiology is on the line. They want to know which side of the neck of this patient of mine they need to do the biopsy on. So I pull up her chart. It's a 21-year-old male with history of fatigue that's been going on for about 2 years, actually. History of migraines and an incidental finding of cervical chain lymphadenopathy. So lymphadenopathy, right, is enlargement of lymph nodes. Lymph nodes, normal size is up to 1 centimeter. And if it's larger than that, we have to keep a close eye on it. And I had ordered labs on her or on him, and his white blood cell count came back normal. However, he has history of mono. His EBV IgG was positive. I did an ultrasound, which showed that there was a 2 centimeter lymph node in the left posterior cervical chain, like in the back, under the mastoid. And then I did a follow-up CT with contrast, which again shows a 2 centimeter lymph node. And not just that, it was showing multiple enlarged lymph nodes bilaterally. So this is a little concerning, right, guys? So what are we thinking? What are the differentials? I mean, I pretty much stated over there, but so we have to think about, is this just a lymph node enlargement that is just because of some benign infection, right? So you could have upper respiratory infections like sinus infections, ear infections. You could have pneumonia, lower respiratory infections. You could have folliculitis, in fact, like, along your face, neck, suboccipital area that will sometimes cause lymph node enlargement, especially along the posterior chain. But then there are a few other things, like he has history of EBV. So could this be a chronic active EBV? And this person is also sexually active. So we have to test them for STDs, like syphilis and HIV. And then the other concern is lymphoma. Also, a person who has had mono, there's a potential risk of developing lymphoma. So these are all my concerns. So we also have to do a chest x-ray because we may see lymphadenopathy along the hilum around the heart. And that came back negative, that was fine. And then the next step is doing a lymph node biopsy, which is why I had ordered this. And so I let the radiologist know, hey, it's the left side that you need to biopsy. And I had my staff send over the image result, which I thought would have already gotten to them when I put in the referral. But as you will know, in healthcare, so many things can fall apart, and it's always our responsibility to be very patient and to follow through on things. All right. So 8:45 now, I finally talked to IR. I reordered all the orders with the specifics, and now I'm finally going to see the 8:30 patient. So the 8:30 patient is a 70-year-old female. He's a patient, she's a patient of my partner's. Sorry, because I'm trying to change around patient demographics, like I said, to hide their real identity. So the 70-year-old female is my partner's patient, and I'm seeing her for the first time. It's an acute visit because the patient is feeling like she's having acid reflux. She has history of cholesterol, high blood pressure, acid reflux. And so the chief complaint is bloating and acid reflux. Doctor, I had a key lime pie 2 days ago, and ever since then, I'm just having some bloating and I'm having heartburn. Oh, also on the side, my urine is really dark for the past couple of days. They always throw those things in there, but every detail matters. And so those are the vitals over there. And I was talking to the patient, this person I've never seen before, and I'm looking at them and I'm like, your eyes look a little yellow to me. Do they look yellow to you? And they're like, no, they're fine. My eyes are fine. I'm like, how about your husband? Did he say anything? And she's the husband isn't there with her. She's like, no, he didn't mention anything. I'm like, okay, well, let me examine you. I did an abdominal exam. Everything looked fine. I asked her, hey, do you drink a lot? The patient's like, maybe one, I don't know, margarita per night. I'm like, okay, well, hold off on it. I'm going to do a couple of labs on you. I need to check what do we need to check for here, guys? What are the differentials? Why would this person's eyes be a little jaundiced? What labs do I want to know right now?
Maybe something is wrong with her liver because, like you said,
exactly.
Be drinking.
Exactly. So exactly, that's what I'm thinking. I'm like, oh dear, something with the liver. I want to check her liver functions. I want to get a bilirubin. I did an in-house urinalysis, and guess what it shows? It's showing that the bilirubin is elevated, and that's unconjugated bilirubin. So this patient is having jaundice going on. And then I ordered labs and they're going to come back the next day, but I'm home and I'm reading up on all of this. And this is what's so interesting. It's just like all these kind of different cases are just thrown at you, and you are a constant lifelong learner. You go home, you read, not too long, just at least like 15, 30 minutes. And so I'm like, oh, and these are all just reminders from med school. You possibly cannot remember everything in med school. As an FP, especially, like you are just getting very good at managing your resources and knowing which resources to use and compiling resources. I don't have the biggest memory in the world, so I just kind of constantly learn. So I was looking, I'm like, there's pre-hepatic, intra-hepatic, and post-hepatic causes for jaundice. So pre-hepatic is what? It's hemolysis, red blood cells breaking down and releasing bilirubin, right? So I would want to do a CBC to make sure the person's not becoming anemic for some reason and their RDW isn't high. And then intra-hepatic is like liver issues from drinking too much alcohol, cirrhosis, hepatitis, viral, non-viral, so different reasons. Then there's post-hepatic obstruction. So you could have a stone in the common bile duct or something, right? And that's causing backup of everything. You could have a mass or a tumor growing. So these were all the differentials. I was very curious to know what was going on. The next day, we looked at the liver functions and they came back really high, not in the thousands, thank God, but they were like 400s to 500s, which is still pretty high. The bilirubin also came back 4 times what it should be. And then we trended it in 2 days, and the bilirubin went up to like 12. And we ordered stat imaging on the patient. And thankfully, it didn't show a tumor or anything, but we sent her to GI right away, sent over all the results to them, and they're basically going to do what's called a ERCP. And the ERCP is like an endoscopy with fluoroscopy to look for any problems with, like, you know, the common bile duct, the pancreas, and all of that. So does that make sense? There are a couple of other questions coming up, so I want to get through these cases to kind of leave some time and be able to answer your questions too. So, I mean, I just want to let you guys know, I have a life outside of the clinic, you know, things that matter to me. Also, in addition to my profession, my patients are my family. I love to travel. I love to do yoga. My whole family, they're all in medicine. You know, my husband's a pharmacist. My mother-in-law is a nurse. She just retired over the weekend. She's really sad and crying about it, literally right now. My brother-in-law is a dentist, and my other brother-in-law is in medical school right now. And my mom, she's a social worker in the hospital. So everybody except my dog, which I call her my therapy dog, I guess. So then she's also a healthcare worker. And we travel a lot. I also do yoga on the side. That really keeps me de-stressed. You know, that's another outlet for me. And I teach yoga. I go by the Yogi Doc, and I have a website, and I send out newsletters, and I try to stay happy because that's what life is about, right? So I have a couple of questions here that I'm going to go through and answer, okay? So do you feel like you have a good work-life balance as an FP? So that's a great question, because I just answered that. I do. I really do. And I take pride in that. You know, I don't work the weekends, and I'm only on call 1 week the whole year. And I'm off today, you know, like, so these are the kind of things that you negotiate and you ask for. You look at vacation, PTO, weekends, the hours. What you want is what you get, unless you lose that internal connection with yourself. Like, going into medicine, we have to develop the ability to kind of connect with our true inner self and know what we want. Because if we know what we want, we'll get that. And if you feel miserable where you're at, that probably means that that's not what you want. How much time would you spend charting a day? Okay, so I'm charting with the patients, and then I probably spend an additional 30 minutes charting outside of the visits. So like I said, I'm done seeing my patients around 5. I finish my charting at 5:30. Then I'm doing callbacks till 6, and any extra paperwork. Like, I have to sign off on many orders and physical therapy orders and outside home health orders and things like that. So about 30 extra minutes. But I also use Dragon, the dictation. It's amazing. How do you deal with the burden of your patient's emotional trauma? That's a very good question. You know, it's something that you have to learn how to not have countertransference. And especially as a physician who does manual therapy, I do osteopathic manual therapy. And during that too, I take on a lot of my patients' pain. In the beginning, in residency, and in my initial years of practice, I noticed that if my patient came in for neck pain and I did manual therapy and I released everything, then that evening or next day, I'm noticing I'm having neck pain. In the beginning, I didn't add it up, and it was just so weird. But then in our training, we were actually taught about countertransference, and that can happen with manual therapy. It can happen, for example, that patient who was having the decrease in appetite, who just kind of unburdened her whole history in front of us. We become very well trained in professionally handling that with extreme empathy, but in a professional way that we do not personally get affected. And so it is a fine balance. You know, you want to listen, you don't want to interject them. You feel their pain, you do feel bad for them, but you also feel empowered that they trusted you with that knowledge and that you're in a position to treat them and help them, right? So I hope that answers the question. And I'm also very spiritual. Like I said, you know, I do yoga on the side, I go to church and all these things, and those kind of things also kind of helps me unburden myself. When you first started as FP, find it difficult to assess a patient's symptoms to make a decision? Do you feel like it's gotten easier with experience? Oh, for sure. In the beginning, oh my God, I would have so many resources in my pockets. Every pocket, I would get like a white coat with inside pocket, multiple pockets. It was full of like, it was a heavy white coat. And right now, I'm like, I have my books in my office. I have FP notebook that I use. I have UpToDate on my phone that I always use, and never hesitate to tell a patient, hey, that's something I'm not too sure about. Let me look it up. Always, always do that. Never try to pretend that you know something you don't, or make a recommendation where you're not sure about it. If you are honest with your patient and you tell them, that's something new to me, let me look it up really quickly. You could step out and look it up, or you could look it up right there. In the beginning of my training, people didn't receive it so well when we look at our phone, but now everything is on our phone. I have Hippocrates on the phone, FP notebook, UpToDate, everything. And patients are very patient. When you are looking something up for them and they respect that, they honor that. And so I still struggle with many things. Like my weakness is dermatology, but my partner is pretty good at it. So whenever I have a derm case, I'll call him over and consult with him as well. And then we'll look it up together later, So there's always going to be weaknesses, guys. We're not going to be great at everything. Acknowledge that, know what our weaknesses are, and find ways to improve those skills through CMEs, through, just asking help from your colleagues. That's what I love about working with other providers, is that everybody's strengths are different. I'm really good at psych, musculoskeletal medicine, diabetes. I love it. And my partner's skill sets it could be different, right? So we all put our brains together, and that's what it is. Medicine, especially in FP, is a very collaborative field. Do you have any study techniques that you use or have used in med school? So that's a wonderful question. One thing I would highly, highly recommend, guys, is start keeping your resources together. Evernote, that was one of the best advice that a resident told me when I was in med school. He told me he started compiling everything per subject, like endocrinology, dermatology, in Evernote. Because one thing you're going to notice as you go from pre-med to med school to residency to fellowship, you start losing important things. And it's not about how much you retain here, but it's about how you put those resources together. And in our age with technology, it's very easy. So learning how to compile the knowledge and putting it in a way that is easily accessible for you to check over and over again. And it's only through repetition that we will become very good at many, many things. These are all wonderful questions. I'm so excited that you guys are so engaged. Let me see. Are there any other questions, guys? Let's give them some more time to ask any last minute questions. Thanks again. I really enjoyed talking to all of you, and to be able to share my experience with everybody. Being a doctor isn't for everybody, period. If you go into it, it should not be for the money, whether it's FP or the highest ranking one was orthopedics, I think. Otherwise, you get burned out, you have to go into it for your passion, for the service, and that satisfaction from helping others. Oh, thank you, everybody. I appreciate all of you who attended this, and thank you, Medical Marvel, for the opportunity to do this virtual shadowing.
So much, Dr. James. I loved hearing about your experiences and all your insight, really, and thank you for answering all our questions.
You're welcome. Anytime.
Have a great day. Thank you.
You too. All of you, take care. Bye.